Professor Francois Venter will begin, and his focus will be on novel therapeutics and diagnostics in prevention. Dr. Venter is well-known to most of our audience. He is the director and head of Essential, which is a research and advocacy unit. He has been at the forefront of research and advocacy in the field of HIV for over 2 decades in South Africa.
So hi, everybody. I'm Francois Venter, and welcome to this session, which is going to be a real massive rush through all the new HIV prevention stuff that's out there, which is actually an extremely exciting area. These are my various disclosures. I do a lot of work within the prevention arena, so I'm hoping that I can bring some of our data to bear. I think the big news, and I think everybody who's on this call knows this, is that we've made sex safe. If you take it as if you're HIV negative and you take pre-exposure prophylaxis or post-exposure prophylaxis and you're adherent, you won't get the virus. And if you're HIV positive and your viral load's undetectable, you're untransmissible. And the partner study, which looked at these incredibly high-risk men, is probably the hardest data we actually have. And we're moving to a situation where we're even going to on-demand PrEP, slowly making its way into guidelines, and the evidence base for that's increasing. In my own programs, a study that we have looking at sex workers in central Johannesburg, we have yet to have a properly documented HIV seroconversion on PrEP. So these drugs really work in a way that is unprecedented in terms of modern medicine. You don't see this in malaria, you don't even see this in contraception. These are wonderful tools to have to stop HIV transmission. They're also starting to have an impact at the public health level, and it's probably a combination. It's not really PrEP, it's more treatment, I think, but also circumcision, condoms, all the other good stuff, is having a profound drop in HIV new incidence infections in the last few years in the Southern African region. The data is less clear in many other countries, but even in richer countries where PrEP seems to have a bigger role, incidence seems to be dropping rapidly. And while we're not happy with the end of AIDS rhetoric, we still have a massive problem. You can see here from the South African data, which is very well collected, a fairly dramatic drop, particularly amongst women, just in the space of 5 years. And then here you can show it very well shown in the groups that we really worry about, young people, that drop is amongst both men and women, but particularly amongst women. Now, this is in the face of an imperfect 1990 program. Now, while South Africa has steadily made progress here, and in fact, I have data which I can't show you here because I haven't got the slides yet, has attained 90, the last 90, in fact, has people on antiretrovirals, over 90% have viral load suppressed. We're still not getting to most people in terms of our treatment programs. Which is a pity because in many other countries, these 6 are notable, including some in Southern Africa, having attained the 1990 targets. But it does give us echoes of hope, and we're seeing from the media, from the donors, this idea that we can get control of the epidemic. But what do we know? We know that the epidemic continues to rage in young people, and that the transmission rate of transmission that happens after the age of 32, certainly in sub-Saharan Africa, is actually relatively small. And that is good news because it means that we can focus on that group. The bad news is that group is actually really difficult to get to. We also know that for both treatment and prevention programs, men and young people are missing, and we need to be focusing more on that. However, we have these incredibly powerful drugs now to stop the epidemic in its tracks. And it does mean for people like me and others involved in public health, it's like, think, if we just laser-like went after those 18 to 32-year-olds, not that we ignore the people after 32, but to be honest, those ones after 32 are doing pretty well in all the programs. They're coming relatively early, they're getting their drugs, they're staying on their drugs. This age group is the group that we're really not getting to. Could we incentivize them? Could we drive them into programs for testing, incentivize them to stay on their PrEP, to stay on their ART, to come back for their appointments, and expand the offering of PrEP and PEP to this group as in more innovative ways. So there's plenty for us to do, but let's talk a little bit about which drugs we have to do it with. So there's a whole lot of things I'm not going to talk about around, as I mentioned, treatment works, but it's child prevention. We've almost removed HIV transmission to children. Circumcision works, needle exchange programs, and that's becoming steadily more of an issue in central cities in Southern Africa. Post-exposure prophylaxis and PrEP works. And then programs we forget that focus on specific risk groups, looks at gay men, at sex workers, at intravenous drug users work well. And then finally, the non-sexy stuff like condoms, which we've been there since time began. So all of this stuff works. I'm not going to talk about it specifically. And it comes in the context of a whole range of other stuff that's coming on its way. We're hoping that the vaccines will finally declare themselves, that some of the microbicides will show some benefit. We've seen the dipivirine ring making its way into possible registration quite soon, and all the other good stuff that we know and love. We also know all about the barriers to care and treatment. And I love this slide because there's one there on the right that everyone doesn't acknowledge, and that's just simply forgetting. And certainly for many of my patients, all know that the distances, poverty, stigma, all that stuff is important to take into account. So with treatment, we've had this incredible change in paradigm where we've gone from highly toxic single doses to lots and lots of tablets to a situation now where the injectables are part and parcel of the landscape. And we're seeing exciting registrations of injectable antiretrovirals now that we've just entered into the integrase inhibitor era. So we're sitting at the moment in Southern Africa with one tablet once a day, which is very well tolerated with very few side effects. But we're now eyeing the idea of an injection every few months and even maybe an implantable every year or so. And this is also showing up in the prevention paradigm where the PEP, the old-fashioned PEP we had, was really, really toxic. And then from about 2010, having oral PrEP, which is highly, highly effective. The addition of the dipivirine ring, as I said, I'm not going to talk about the dipivirine ring, but that's looking like it's going to be entering registration in the region. And then the new injectable PrEP, which is showing phenomenal benefit, even in the last few weeks. Exciting data coming out on that. So what we're giving at the moment for post-exposure prophylaxis is usually an integrase inhibitor based, usually dolutegravir, coupled with tenofovir, in richer countries with TAF instead of tenofovir, plus 3TC. And the only real reason we move away from that is if there's pretty much renal issues, or if a woman's in her first trimester, or if there's a real concern about resistance in the source patient. But this seems to be the standard of care across the world, and it's great news for us because this drug is readily available in all the clinics as treatment, and now we can use it for post-exposure prophylaxis. However, for oral PrEP, we don't add the integrase inhibitors, and there's a lot of reasons around that. But it's not really necessary because if you take tenofovir FTC or 3TC, it's highly, highly effective. And this has now been replaced with TAF, as I'll talk about in a moment, in richer countries. There's a whole of stuff that goes with this. It's not just the drugs. You need to support them, and the use of text messages and all sorts of other incentive-based stuff has been used to try and help people to be adherent, not just to PrEP and PEP, but also to treatment. And it's important, particularly in the context of PrEP, where low adherence levels have been reported from multiple places, and lots of falling off of programs as we go forward. So the programmatic stuff in some ways is much harder than the side effect stuff. We have lots and lots of stuff that the combinations that are approved by the major regulators or in the process of being approved, as well as stuff like these neutralizing antibodies. We're not sure if they're going to be practical, but there's a massive amount of data that's starting to enter the field in terms of its use in terms of prophylaxis. And obviously the implantable ones I talked about earlier. At the moment, WHO country recommendations firmly around the PrEP stuff, firmly recommends tenofovir, emtricitabine or lamivudine as PrEP, and that the PEP recommendations are also very, very similar to the ones that our countries are using already. I haven't put the Southern African guidelines here, but in general, they meld the level of creatinine clearance monitoring and other things that go with tenofovir vary, and for most of the countries, we don't have TAF available yet unless it's through research programs. Discover was the study that looked at TAF versus tenofovir, and unfortunately, the study was only, with much controversy, was only done in men. What was interesting about the studies in both arms, TAF and tenofovir were very, very, very effective. Like they had almost no breakthrough infections with this. Again, it's really reassuring that this technology, if you take it, works like a bomb. However, they did not study women, and that those studies are now only being applied, and that has meant that we're not able to recommend TAF for women in terms of this as yet. And I'm fairly comfortable that eventually we will. It's just a pity that these studies were not in progress or done as quickly as the male studies. And I'll come back to that in a moment. So independent studies, this study now looking at cabotegravir as a prophylaxis for PrEP, has also been used and has been highly effective. This study was done in men, and the results released just a few months ago, demonstrating that cabotegravir, injectable cabotegravir, was actually much better than tenofovir oral therapy. And this is probably on the basis that the injectable is much more effective. What is really exciting is just last week, the similar study done in women was halted with very similar results. In fact, it looked even more safe than amongst men. And this really has changed the PrEP world in a way that we haven't seen it in the past. So it's a very, very exciting time to be alive in terms of HIV prevention. The injectables and implantables are all in various stage 1s and 2s and 3s. It's not just the integrase inhibitors. It's a whole range of drugs, including drugs like islatravir, some other novel NNRTIs. So we really suddenly have this pipeline of injectables and implantables that are coming through the mill, and which are, we're getting data on it just in the last year. We've had a flurry of data on this issue. So very, very exciting time in the prevention area as well, because all the stuff that we're battling with in terms of adherence is going to be needed. Some of that will be solved with the injectables. The ring, as I said, the pivoting ring is being licensed. It's difficult to see what the role is going to be. It might have a niche role. It's not nearly as effective as oral tenofovir in adherent patients or the injectable, but maybe it'll be an add-on. And I think it needs some smart minds to be looking at that. Cost, we're always very cost sensitive, and with the long actings, all of this is going to come down to cost. They're almost certainly going to be more clear, will they be more expensive than, say, 3 months of oral therapy? And then the practicalities of where we put this, the cold chains, all the stuff that who gets it, who do we prioritize? That stuff we are going to need to tackle. But it is an exciting world, and I'm very, very excited about how we are finally looking down the barrel of an HIV generation where we'll at least have some control of the infection rates, particularly in that magic group between the ages of 18 and 32. And thank you very much for your time.